All right. Well, hello, Dr. Solomon. Good to see you again. For those who don't know, I'm Ashley. I'm the program director for IVUmed. We're happy to give another virtual lecture to all of you in Ethiopia. And it seems like Dr. Jean-Pierre there is in Canada. I'd like to introduce Dr. Metzler. He specializes in endourology in Portland, Oregon. I'll go ahead and give the floor to him and we'll get started.
Okay, sound great. Let's start.
Exactly. Well, yeah, as Ashley said, I specialize in endourology and particularly related to minimally invasive procedures for kidney stones, endoscopy, and also some robotic upper tract reconstruction like pyeloplasties and ureteroplasties and things like that. I'm happy to talk about any of that, as well as I started a multidisciplinary kidney stone prevention clinic here at OHSU, so I'm happy to speak on that as well. The topic of this particular talk, though, is about the use of ultrasound for procedures on the kidney, particularly for guiding PCNL access. Since we have a relatively small group here, if it works, I'd love to hear people's background in this particular area and see where you're at. So I'm not just talking at you, but also meeting you where you're at and have a little better understanding of what you do now. So I don't know if Dr. Solomon, if you could kind of let me know where most of the stone care is done in your hospital in Ethiopia and what procedures you do most commonly for stones, and what access you have to ultrasound or the equipment to do PCNLs.
Yeah. Thank you, Doctor. It's nice to meet you. We mainly focus on the open surgeries because we do have a shortage of instruments. We are starting the standard PCNL. Otherwise, most of the cases are especially for stone disease. About the renal stones, we mostly depend on open surgeries. But we are still starting the PCNL. We have some experienced urologists in our hospital, but there is a problem with the instruments. So seldomly we'll perform this PCNL. For the ureteric stone and for the others, we do have URS, but still there is a problem in supply of this instrument from the government. We are working on the government hospital. As you know, this is a third world country. Very difficult to get the supplies because there is no production in this country. Mainly depend from the outside, mainly from stores or Olympus, or sometimes from a cheap product from India. So that supply is still interrupted in our country. Otherwise, we during also our residency, we performed a lot of URS cases. Still, we do have some instrument regarding to the flexible ureteroscope, but there is also a shortage in some supplies. So we are just starting this endourology practice in our country. Otherwise, there are some urologists who are experienced with the standard, especially with the prone position. Mm-hmm. I've seen that during my stay in India, both supine and prone PCNL was performed, and some urologists in our country, in some center also, they are still trying to do the PCNL with ultrasound. Otherwise, mainly we have strong and big stones. So in that way, we mainly depend on these open surgeries.
Gotcha. And can I ask as a follow-up, it sounds like the major limitation right now is the access to scopes. Is that the most limiting kind of technology or instruments that you need?
So currently in our hospital, we do have this scope, especially the PCNL. We do have the nephroscope, both big and smaller one, the mini perks, but we have a problem with the energy source. So we were depending on the pneumatic energy, but it's the compressor and the likes were broken, so it's gone. We had also laser previously, like 5 years back, but still it's broken, so was taken to the supplier. But it was we were told that this laser should be changed with a new one. So the government was unable to give us this instrument again. So we are mainly have a problem with the energy source rather than the scopes. Regarding to the flexible one, we don't have the access keys. That's why our problem. That's the only problem. Otherwise, we do have the both C-arm. It was just brought from both from like 5 years back, but still working. Mainly our problem is with the energy source, both for RIRS and for PCNL.
Gotcha. And what kind of access do you have to an ultrasound machine in the operating room?
Yeah, we do have ultrasound. We had the 2 ultrasound in our unit. So one of the ultrasound could be taken to the OR table so that we can perform this ultrasound guided PCNL procedure.
Yeah. Well, I also have young kids that like to jump on my calls, so I know.
Yeah.
what you're going through.
Yeah, she just entered into our room. That's why. Sorry.
Well, thanks for sharing that. Can I ask Dr. Mohammed, who's on the call, to share this experience with stones and where you are and what you're doing? He's not available right now. How about Dr. Pierre up in Ottawa?
So we have a kind of socialized healthcare as well. So it's all government run. I'm lucky. I'm in one of the major cities, technically the capital of the country. We have fluoroscopy, lasers. We tend to have ureteral access sheaths available. Now, the lasers aren't always the most reliable, but they usually work for the most part. I do perks. I usually get access via fluoroscopy. I can get into a kidney via ultrasound, but I'm not sure I do as good a job, just because I still am a bit confused about choosing the right calyx, particularly for branch stones, where you can't see the stone as well on ultrasound. So I mean, kind of a hack job when I try to do it via ultrasound in those instances. I usually have fluoro to help me kind of pick the calyx and get better access to it. But most of the stuff we tend to have available. We have a shock pulse lithotripter. The Boston Scientific and the higher end lithotripters with multimodal functions tend to be a bit outside our price range. So yeah, but it still works out okay.
Great. Thanks for sharing. Hopefully this is appropriate for you, because I certainly still use fluoroscopy in all my cases, and ultrasound it gets you 90% of the way there most of the time. I think it'd be very helpful. And then sorry if I mispronounced this, but Dr. Gerowat is able to comment on your history with stones. Okay. Well, I'll go ahead and get started then, and please feel free to jump in and ask any questions. I don't think this will take the whole hour, and I want it to be bilateral and conversant. Is if anything doesn't make sense, or if you have questions, I'd love to hear them. So the primary goal of this procedure is presentation is to talk about procedural ultrasound of the kidney, really basics of ultrasound and how we utilize it, and then how I incorporate it into my practice for PCNLs. So I'll go ahead and get started. So the objectives here is the basic use of an ultrasound machine and the probe, a little bit about knobology, which is sometimes what we call learning the settings of the ultrasound and how to use them to improve your image quality. And then looking at the kidney anatomy itself under ultrasound, and also the use of the probe and the manipulation, so that we're speaking the same language when we talk about how to adjust the probe and improve our imaging. And then finally, needle insertion for access. Ultrasound physics in brief, I'm not a physicist, but we know that ultrasound uses sound waves or vibrations. And all these vibrations have a frequency, and the frequency is very important to kind of understand. The unit of frequency is the hertz, or Hz. Human hearing, just for reference, is anywhere between 20 and 20 kilohertz. Ultrasound is 2 to 18 millihertz, so much higher frequencies that are giving us these pictures, obviously. The probe we often refer to, the device that we put on the patient's skin to get our imaging, is also technically the transducer. It both emits the ultrasound sound waves, but also receives them. And the different probes that we've seen around the hospital are optimized for different hertz ranges, which is important to keep in mind when selecting them. These are common ones that we see in urology, and hopefully you have access to all three types. The curved array abdominal transducer is the one that I use most in practice in the operating room for kidney ultrasound. This ultrasound transducer has a lower hertz range, which is why it's useful for the kidneys and bladder, because they're deeper structures, and so you need the lower frequency in order to have the sound waves penetrate the tissue depth that you need in order to visualize these structures. In comparison, we have the linear transducer, which we often see used by our anesthesia colleagues when they're getting peripheral lines in. This is at a much higher hertz range, and it can also be useful for imaging the scrotum, penis, and urethra. I've often used it in practice when evaluating penile fracture to look for disruption of the tunica, so it's valuable for those more superficial imaging needs. And then we have the convex transducer, which we're all familiar with for transrectal biopsies of the prostate, and that again is a higher frequency range. So in general, lower frequency gives you more depth of penetration, but less detail. That's the trade-off. Higher frequency gives less depth and more detail. And the way that I use this in my practice is I'm not switching them out the probe so often, but you can set the frequency, as we'll talk about, in order to make these trade-offs most beneficial for producing a high quality image. For just the terminology of probe movement in the operating room, and as I'm teaching residents, it's really important that we're all using the same language when we're talking about how to adjust the probe positioning in order to give you the best image or to correct towards the target that we have in mind. And so the first term is sliding the probe. So that's when you're moving the probe across the surface of the skin, which obviously changes the image in a sort of a direct parallel position relative to the skin, but isn't changing the angle of the probe relative to your target. In contrast, tilting or fanning the probe, you don't move the probe relative to the skin position, but you're merely changing the angle of the probe in order to have the plane of imaging that's coming out of the probe relative to the organ to fan back and forth. I use that a lot, primarily when imaging the kidney, and once I've picked the location that's appropriate for puncture, I'm fanning back and forth from that in order to create a clear picture of the kidney. And there's rotating, which is pretty self-explanatory. The probe is moving across the skin, the patient's skin. However, the position is fixed. Rotation is really important when trying to align your plane of imaging with the more with either the transverse or the longitudinal plane of the kidney itself. So you'll find that just slight rotations can bring more of the kind of traditional image of the kidney that we think about when doing these punctures into view. And it's very easy to be taking an oblique angle of the kidney if you're not perfectly rotated in alignment with the vertical axis of the kidney. And then there's rocking, which is where you're actually kind of tilting, but not in a different axis, the probe itself, so that the sort of edge of the probe digs into the skin or pushes into the skin, and that changes your trajectory of both the imaging plane, but also if you're using a biopsy guide, it changes the way that the biopsy guide aligns with your target. And so that's really important to be able to use well when placing a needle into the kidney. The angle of reflection of the ultrasound image is also important to keep in mind when you're, particularly when you're doing procedural ultrasound with the needle. This image is a little bit confusing, but what I wanted to demonstrate is you can think about these sound waves coming out of the probe and hitting a hyperechoic, which we'll talk about in a minute, hyperechoic target. Now, the more perpendicular the target surface is to the waves coming out of your, the sound waves coming out of your probe, the brighter the image will be because the reflection is directly back to the probe. You can see in contrast, when you either turn the probe relative to a perpendicular structure, a lot of the imaging, or a lot of the sound waves bounce out of the plane of the transducer, and so fewer of them get back to the receiver portion of the transducer in order to be translated into imaging. So if you're coming in then at an oblique angle with your needle or whatever surface you're looking at, you actually want to tilt or fan your probe in order to sort of recreate that perpendicular angle from the surface of the target to the probe, because if you continue to have your probe pointing directly perpendicular to the skin, you're actually going to lose a lot of the imaging sound waves that are coming back again. And so that's important too when you're thinking about using a biopsy guide. There'll often be different angles that are available to you for that biopsy guide. And the more sort of vertical the guide is, as in it's coming straight down, I don't know if you can see my mouse, but coming straight down through the tissue, that directly vertical needle is going to be nearly invisible because the sound waves aren't going to be reflecting off of it back to the probe because they're essentially parallel. And you can see just a slight difference between A and B. A difference in this, just a few degrees, gives you a much brighter signal of the needle. And you can see that they've achieved that not by changing the trajectory of the needle necessarily, but by rocking the probe in order to make the surface of the needle more perpendicular. So that's an important trick to keep in mind as we move forward. So to get to more terminology, we've got how we talked about how we move the probe, the terminology for that, and now this is the terminology, the image that we create with the ultrasound probe. So hopefully you're used to this terminology, seeing it in your ultrasound reports, but the first term is hyperechoic, and that's when these are all relative terms. That's when the structure that you're referring to, your target structure, is much brighter or more intense than the surrounding structures. You could say that's a hyperechoic structure. If compared to the surrounding structures, there's a lot less intensity or it's a lot less bright, that would be hypoechoic. If it's the same as the surrounding tissue, it would be isoechoic. And then if there's a complete lack of signal, it would be anechoic. So again, we don't want to think about this in terms of density. That's CT terminology. It's about hyperechoic, hypoechoic, or isoechoic relative to the surroundings. And I refer to that as the intensity of the foci or of the target. So just thinking about the different tissues that we can image with the ultrasound and the utility of that and how we see the echogenicity change. We can think about all these different tissues, and one of which is a fluid-filled lumen. So blood vessels is a great example, but also the urinary tract or bladder. What you see is a very anechoic central area that's fluid-filled, but then what you'll get is a post-acoustic shadowing. So that's when the ultrasound waves travel through the liquid media very quickly. They will all pile up on the back end of the structure and all reflect back at the same time. And that's when you get a post-acoustic enhancement, or that brightness on the far aspect of the structure when it is anechoic like that. So important to keep in mind, this isn't necessarily a brighter spot down here below the blood vessel lumen, but it's an effect of the sound waves traveling through that media and then bouncing back all at the same time. Now, when we look at organs like the kidney that are more heterogeneous in their structures and their echogenicity, we see that the sound waves can travel at various speeds and give various reflections in order to create an image. So you see the first structure is fat, which is hyperechoic, bounces back a lot of sound waves. Then you see the parenchyma or the cortex, and we'll talk about this a little bit more in detail. And then you see a hyperechoic area, which is the perirenal fat, and then maybe some anechoic calyces, which are really your target for puncturing into the kidney. You can see a complete echogenic structure like the diaphragm, which is all collagen fibers, and bounces back all of those tissues, all of those signals, because the tissue is so reflective. You can see structures that are sort of air-filled or will scatter the ultrasound waves, which is why you get such a kind of messy image where you lose there's no shadowing, but it's sort of this mess of echogenicity beyond the air-filled area, like the lumen of the colon or small bowel or lung, because the ultrasound waves can't travel through that because they're all being reflected back at various angles, and you're losing a lot of them. And then something like bone, you're going to get a very hyperechoic superficial aspect of it, and then you get shadowing, which is basically where no ultrasound waves can travel through that medium. They all reflect back, and so you cannot see beyond it, and that's reflected by the shadow. And that's really important in stones, as we'll see in just a little bit. So the goals of procedural ultrasound specifically is to define normal kidney anatomy, identify the pathology such as stones, masses, or hydronephrosis, identify hazards to the procedure that you're about to perform, such as vessels, pleura, liver, spleen, and bowel, and then guide your intervention and ultimately, hopefully, improve your access and limit the use of radiation. So normal renal anatomy, I want to talk to you briefly. It's important. A few caveats are important. So you can see a cadaveric specimen here we're all familiar with. You have the cortex, you have the medulla, and then you have the collecting system. And what they've removed here is a perinephric fat, which you can see here in this cartoon is that yellow stuff. Well, that's pretty prominent and important on ultrasound. And the comparisons between that perinephric fat, which is the bright stuff you can see in the middle of the kidney, and the surrounding structures is pretty essential for identifying your calyx properly. And one point I want to make is that you can see the cortex is hypoechoic, but the medulla of the kidney, especially in a patient that's well hydrated or young and has healthy tissues, the medulla themselves can be so hypoechoic that they're almost anechoic, and you might mistake that medulla as a fluid-filled calyx. Well, the way that you know that that's not, in fact, a calyx is that it's still in the cortex of the kidney and is not within the perinephric fat that is normally surrounding our collecting system within the kidney. And so what you're looking for here on the ultrasound, this is a healthy kidney without any hydronephrosis, so they're hard to see because they're all collapsed. But this darker structure within the perinephric fat is more likely to be your calyx. than these medulla out in the cortex themselves. People can often get confused by putting a needle in there and not getting a return of urine. That's because you're still in the kidney. So obtaining a quality image, the goals of making a good picture here is getting the kidney in the appropriate size, the proper orientation, getting a uniform and sufficient brightness of the structures, and then adequate sharpness and focus is the secondary goal. And the way that you can achieve these goals is by choosing the correct transducer, choosing the correct frequency, adjusting the depth. We'll talk about time gain compensation, or gain, which is equivalent to sort of brightness of the signal, and then the focus on some machines, although a lot of machines have gone to auto-focusing. First, we'll talk about orientation. So this the sort of a clinical standard here is when you're looking at the kidney in a sagittal view, the head is always to the left, feet are always to the right of the image, and then the top is always going to be close to the probe, and the bottom is always away from the probe. At least with abdominal imaging. With transrectal imaging, it's the opposite, because the prostate is above the probe. In the transverse view, the right is always going to be on the left side of the image, left is always going to be on the right side of the image, and same with the closer and farther away from the probe. Now, this is the sort of proper orientation, the clinically accepted orientation, but in the operating room itself, I don't always follow this convention. When the patient is set up, let's say, in a supine position, and it's a left-sided surgery, well, I'm on the left side of the patient. My ultrasound is usually across the table from me, and so the patient's head is going to be to my right. Well, I'll switch the image with a left-right flip of just the way the image is presented, in order to get that aligned, that imaging modality to be aligned with what I'm looking at in terms of the patient. People have different opinions about that, but I find that it makes a lot more sense that if the needle is coming into the kidney from the left, that it should come in from the left on the image itself. So again, this is the correct convention, but that's adjustable depending on what you prefer on the operator. So gain is so adjusting your gain. So that's essentially equivalent to the brightness or the intensity of the image, and there's a knob that allows you to adjust the entirety of the brightness on the image, which is useful if the setting is not correct, but it doesn't give you a lot of control of what part of the image is bright. And that's where time gain compensation comes in. And you've probably seen these little knobs that can be kind of in all over the place, depending on how many times it got bumped while getting set up. And this correlates to the depth of the image and how bright you want that depth to be. So you can see here, this is a liver, not a kidney, obviously, but it's very, very bright on the top of the screen and very dark on the bottom of the screen. And the way that you would increase the bottom of the screen's gain preferentially relative to the top would be to move the bottom knobs over towards the right. And that's going to increase the brightness here, so that the brightness that you see on the image is actually going to be more uniform. And the way that this is done is essentially it's telling the ultrasound machine to pay more attention to or to emphasize the signal coming from the deeper structures. I think I had a slide on here that got lost, but depth is a very important aspect of this as well. So there's a knob that controls your depth, and you want to match that depth so that you're only including the structures that you care about. It can be often set to a very high depth, like 15 centimeters, and you are going to be imaging your kidney plus a bunch of tissue that's beyond that, which is just going to give you added signal noise and make the detail of your appropriate target structure less clear. So again, when we talked about frequency versus depth, the more you can decrease your depth, the more detail you get. You can think about it, you only have so many sound waves going to your patient and coming back, and you want to restrict the use of those sound waves to only include what you care about, because otherwise you're spending half of your sound waves on imaging structures that you don't care about. So as much as you can, decrease your depth in order to only focus on what you care about, and you'll get better detail. Focus is another thing that you can adjust. Now, and as I mentioned, a lot of machines are moving towards autofocus. So some of them you can't even adjust yourself, but some of the older machines, there's a focal zone that you can change, and you can see here again on the liver, but you have a focal zone that's set up to a very superficial level. Well, you lose a lot of detail on the deeper structures, whereas if you move that focal zone down into the structures that you care about, you're going to get more intensity and more detail of the image at that point. This is different than depth, because depth would actually be shrinking the image so that you're zooming in basically on the structures that you care about. So again, there's two modes of ultrasound. The first that we've been looking at is the B mode, which is grayscale, two-dimensional, and gives you the images that we're all most familiar with. But there's also color Doppler, which is useful to look at if you are concerned about vascularity within the kidney or surrounding structures, like something like a serpiginous splenic vein or something like that might be in your way. If you see a anechoic structure between you and the kidney, you need to be worried that that could either be bowel filled with fluid or some sort of weird vascularity. And you could throw ultrasound, the color Doppler mode on your ultrasound and investigate that structure to see if it lights up with Doppler. And just as a reminder, the red and the blue doesn't mean artery or vein, it means which direction the flow is. So if the direction of the flow is towards your probe, that's going to show up as the warmer colors. If it's away, then it's going to show up as your colder colors. So as I mentioned, you can use it to avoid large blood vessels. And then secondarily, you can use it for this kind of newly described twinkling artifact, which is useful in stone. So if you put color Doppler on in a patient with a kidney stone, you can see here in the upper left-hand corner of these images, there's a suspicion for stone. And if you put color Doppler on that, you can get this twinkling artifact. Now you can see a little bit of Doppler signal there, but the reason it's called twinkling is because it really looks like that. The color Doppler is not pulsatile. It is sort of kind of all over the place and really looks like it's twinkling, which they think that it is due to the many facets of the stone causing a lot of scatter of the ultrasound image, and that gives that artifact. It's not a true Doppler signal, it's an artifact, but it's useful in determining if a hyperechoic structure is in fact a stone. It may twinkle, and there's been studies showing that it's very sensitive and specific for kidneys. Hydronephrosis obviously is an important thing to be able to determine on ultrasound. You can see here, we all are familiar with how this looks in cartoon form, but on ultrasound, you saw a normal kidney before that really had no internal anechoic structures, except maybe tiny vessels. And then as you develop hydronephrosis, which is very common in stone disease, you're going to see the internal structures start to kind of plump up and dilate. And as you get even more severe, you're going to see calyces and their infundibuli dilate, and large renal pelvis going down to the dilated ureter, And then eventually with severe hydronephrosis, you get all of the above plus thinning of the cortex itself. Now, these kidneys with hydronephrosis are the perfect kidneys to start your ultrasound guided access, because as you can see, if you have mild hydronephrosis like this, or a calyx full of stone, you have a very small target that you need to hit with your needle. Whereas if you have a calyx that's blown out like this or this, you can hardly miss. So for stones themselves, I've mentioned a little bit, ultrasound can be very useful, but it's very almost subjective. So it depends on your technician, depends on your patient habitus, the population, and the definitions of the technique that are used. It has a wide range of sensitivity depending on what type of stones we're talking about. And I don't mean, makeup of the stones, but I mean, tiny, small, non-obstructing calyceal stones, or stones within the mid-ureter, you're not going to be able to see. So the sensitivity is range. It can be pretty specific, though, again, improved by that twinkling artifact. It's not very good for small stones, but at the same time, it overcalls a lot of things. And I find this really frustrating in my practice, because I'll often follow up patients after surgery with the ultrasound, and the ultrasonographer will say the patient has tons of residual stones, but what they're really seeing is a little bit of calcific debris, or maybe even clot in the renal pelvis, and they're calling those 1 centimeter stones when they only had a 5 millimeter stone to begin with. And if you follow them up with a KUB or CT scan, there's nothing there. And so you have to take the ultrasound findings with a grain of salt. And I think as you get better and better ultrasound equipment, the techs can see more and more things, and so it's almost a double-edged sword that you get a lot of overcall. Important again to remember that what's also helpful in identifying larger stones is that you're going to get a shadow, and the shadow is a more reliable sign of a true stone. If you get a hyperechoic structure that doesn't have a shadow, it's probably not a stone. And there's also been studies showing that the shadow width more accurately correlates with the true size of the stone, because you get, again, sort of this twinkling artifact, or this halo of hyperechoic signal that can be measured to be, I find, at least 20 to 30% larger than the true stone size if you compare ultrasound to CT. So that's the shadowing. For your ureteral stones, you can not well visualize stones that are in the mid-ureter, as I mentioned. Sometimes in the proximal ureter on a thin patient, you can see them, and then at the UVJ, because you have this nice window of ultrasound through, hopefully a moderately full bladder. And if you have a dilated ureter, you can see this stone here that then has shadowing. Again, if you put the color Doppler on there, you can get a twinkling artifact, so you can diagnose a ureteral vesicle stone. All right, so then let's get to the fun part, which is the percutaneous puncture aspect. Now, there's two different kind of fields of thought about this. Some people teach transverse or out of plane puncture. I never do that. I find that longitudinal is the best approach for me. That keeps the entirety of the needle trajectory in view, and allows you to watch your needle go into the target and make sure that it's not beyond. But the problem with the transverse plane is that if you've gone beyond your imaging plane and into deeper structures, you're not necessarily going to see it unless you're fanning your probe back and forth. And that's the most important thing, is not going too deep. So I do this approach. First, you have to find your target on image and make your image perfect. That's why I spent half of the talk on that, because if you can't find your kidney and find your target and make that image as good as it possibly can be, you shouldn't even start putting needles into things. And once you find your target, don't move the probe. And that can be really hard, because if the patient's breathing, which they should be, even if they're paralyzed with anesthesia, the lungs are inflating, so it's moving the kidney up and down. And I work with a lot of trainees whose instinct is to follow the kidney and keep trying to get that target in view, and you end up chasing your tail, so to speak, with the bouncing of the kidney with respiration. So Once you find your target, don't move your probe and let your target come into view during either peak inspiration or peak exhalation. And then once you are placing your needle, keep it in the plane within the image. Don't chase your needle either, because as soon as you chase your needle, then with your ultrasound probe, by fanning it or rocking it or whatever you're doing to try to get your needle in plane, you've lost your target. And so you might as well start all over. And so it really have to resist the temptation to chase your needle as you're coming in. You really have to move the needle to match the imaging probe, because the imaging plane is your guide. Or if you have a needle biopsy guide, use it. I don't think there's much disadvantage to using it. It takes one more mental gymnastic out of the equation. I recommend holding the probe with your non-dominant hand and getting used to imaging that way, so that your dominant hand is then free to control the needle, which is more needled. This is now kind of an image I borrowed from Dr. Tom Chi at UCSF, where I trained. This is a prone position with the familiar landmarks marked out, including the ribs, the paraspinous muscle, and the iliac crest. And you can see here, this yellow is how he recommends holding the ultrasound probe in order to get a good image of the kidney and your targets. You can go both above or below with your needle. He does not use a guide, which frees him up to have more angles of attack, so to speak. I do use a guide as I work with trainees, and I think it just takes one more thing out of complicating it. So he shows here in the bottom two panels how he would adjust his ultrasound to go either above or below. I often find that I'm going below the ultrasound, and you can either move up or to the rib space above the 12th rib to place your needle, or I do most of my procedures in supine, so I end up doing my needle puncture a lot more lateral than is pictured here. Now, calyx selection, Dr. Pierre mentioned this. I think it's critical, and I still use fluoroscopy oftentimes for this. Now, I do a fair amount of my procedures with endoscopic guidance, because again, I have trainees that can be on the ureteroscope during the procedure and watch the puncture, which is really nice and keeps things safe. But X-ray is also useful, and you can see here just a picture of where you might how you might have done it with fluoroscopy, and there's multiple calyces to select, and which one is it going to be. There's tons of stones in this patient, as you can see from the CT scan here. And I've just done a little three-dimensional reconstruction of the stones that help me think about in my preoperative planning where I'm going to go. So these are kind of in the way here, but my point of this slide is for calyx selection, we would very often go towards the lower pole axis. But you can see here that by selecting the lower pole axis, you have a really acute angle in order to get your nephroscope up to the rest of the stone. And in fact, this middle pole calyx here, which is actually invisible on this retrograde, it's actually right here, this darker calyx overlying the renal pelvis is the one that's full of stone and is pointing up straight at us. And so fluoroscopy, you wouldn't see that, but on ultrasound, it's the first thing you see. I don't have a picture of that particular patient here, but the posterior calyx full of stone would be pointing right up at you. Like you can imagine this posterior calyx pointing right up at the probe and being full of stone, and that's the one you're going to hit because it's the one that's closest to you. And so, you may have had familiarity with sticking a needle into what turned out to be an anterior calyx and really not having a good angle of approach and maybe causing more trauma to the kidney. Well, ultrasound prevents you from doing that. It basically preferentially guides you towards that posterior calyx, and so you worry less about the anterior and posterior confusion between the calyces on fluoroscopy. And I find that that's really important in order to have the best puncture possible. This shows artificial hydronephrosis, or putting a 5-French exchange catheter or scope, whatever you use to get fluid into the kidney. Very helpful in turning what would be not very dilated system into, and that would be hard to puncture into, to a much more dilated system. that's going to be an easier target, and you can do that artificially. Very important though that you remember the air being introduced into the renal pelvis is going to work against you. So if there's air in any of these calyces, it's going to block your ultrasound signal and cause your image at that position to be fuzzier. I see Dr. Pierre asked, if you rotate the C-arm, the interpolar calyx becomes more visible on photo. That's absolutely true and very helpful. But it takes a lot more mental gymnastics to appreciate that. And if you don't know to look for it, sometimes you might not find it. Whereas you can't miss it on ultrasound. The other thing that the ultrasound helps you find is the adjacent organ. So you're not going to see any of this on fluoroscopy, and on ultrasound it's quite obvious. So you can see the liver and the spleen overlying the kidney. You never put a needle through these structures. They're triangular, usually slightly more hyperechoic than the kidney itself, but less echoic than the surrounding fat tissue. And you get a real good sense of that as you start to ultrasound folks. And I recommend, if you have an ultrasound in clinic, or just as you're learning this and have one available in the operating room, just even if you're not going to use it, ultrasound people before they prep when they're all positioned and start getting familiar with the anatomy and with where the surrounding organs are and what area is safe to puncture, which you already know just from your landmarks, that you can confirm and see with ultrasound access as well. And then this is a less good picture, and it shows up a lot better when it's a video, because you get that sparkling effect with bowel when there's fluid filled or air filled fluid in it. So another hazard I want to pay particular attention to when you're going with an upper pole puncture is the pleura. It really depends on the person, but you're never going to see this on fluoroscopy, but on ultrasound you can see it quite clearly. And what we call this is the sliding pleura sign. And it's important to keep in mind that while you can see the lung on ultrasound, the pleura extends much farther beyond the lung. You actually are only going to see where the pleura extends if you have the anesthesiologist give a complete inhalation to maximum volume, and you'll see the lungs slide in that pleural space. And hopefully this reproduces well for you all. Again, it looks a lot better on the actual machine. By the time it's translated into a video file and then into PowerPoint, you lose a lot of fidelity. So I promise you it's not this fuzzy in real life. But you can see here the kidney here, nice hydronephrosis within the perirenal fat. And you can see at the left side here, the lung comes into view as I have the patient take a deep breath, and it slides into this space. And you can see it extended all the way down here. And so you know the pleural space is there. So if you transgress that, you're putting yourself at risk for a hydro or hemothorax or pneumothorax. And so whenever I'm doing an upper pole puncture, which I find I'm doing rarely, I always have the anesthesiologist give me those deep breaths while I'm imaging. All right, so then this is a video showing needle placement. It's a little bit obscured here, and again, the quality has gone down, but you can see this is the target. I'm going along this middle needle guide, and you can see the parenchyma start to move here, and then the kidney rotates a little bit, but at the very last portion there, the needle pops in right there. Again, this is not the best video, so I apologize for that, but it's much clearer than the real thing. You see the needle come into the subcutaneous tissue, it's moving the fat there, then it's pushing on the cortex, and then you pop in. So that's needle placement, and you can get specific echo tip needles for this, but if you don't have access to that, all it is the tip of the needle is roughed up with a pattern etched into it, and you can actually take an 11 blade or whatever and etch your own needle, and all you have to do is kind of make several cuts in all directions in the tip of the last couple millimeters of the needle itself, not the trocar, and that will give you a much better signal on ultrasound. The next one is wire advancement. So now you can see this hyperechoic linear structure in the kidney and the anechoic collecting system down here. And what you'll see is the wire then goes through the needle itself, and you can see it kind of coil and fill the space down here. So there's the needle going in there. And you should be able to see it coil last minute. Trying to fan back and forth to show you the needle actually is in the renal pelvis here. Right there. So you can do that portion under ultrasound, but obviously, under fluoroscopy, it can be a little bit clearer. So that's why I still use fluoroscopy in my operating room. But it takes, multiple fluoroscopy exposures to get your needle in place, and you save all of that by using ultrasound, and instead can just take a single shot to confirm your wire placement and possibly do a retrograde. So even if you're not entirely using ultrasound, which most people do not, and I still use fluoroscopy quite a bit, especially for the dilation portion, because the ultrasound imaging of the balloon dilators is not the best, because they're very not echoic. Fluoroscopy can still be useful, but you cut down on all the exposure that you give to yourself and the patient and your colleagues in the room by getting that initial needle puncture access. And then, there's ways to practice this. So this is a project that I'm working on with a grant from the Urology Care Foundation with the AUA to develop a low-cost surgical simulator for PCNL access, and to basically give you a way for less than a couple of bucks of materials, practice this skill set of placing needles in the appropriate position, advancing wires, and ultimately dilating without any harm to patients. And you can get those skill sets under your belt before you take them to the operating room. So with that, we're past 10 o'clock. We got a little bit of a late start, but I'd be happy to stay on for anybody that has any questions. I see we have a lot more people joining us now, so I didn't get to talk to everybody ahead of time, but I would love to hear your individual experience doing PCNLs or using ultrasound in the operating room, and happy to talk more. Thanks for your attention.
Thank you, Ian.
Is there anybody else in the group in Ethiopia that's doing PCNLs or use ultrasound to look at kidneys in the operating room or clinic?
So maybe I can speak. No one is speaking.
Yeah, please.
Yeah, as I said previously, we don't have that much exposure for this ultrasound guided PCNL unless we only use this ultrasound to insert this nephrostomy tube during the obstruction.
Yeah.
Otherwise, for our during even our residency, we were doing this standard PCNL with a fluoroscopy guided, other than using the ultrasound.
Yeah, and so tell me about how you place nephrostomy tubes, because that's 90% of the battle there in terms of getting access.
Yeah, most of the time we use this flank position and we'll support with the kidney, and then we follow this posterior axillary line, and just before that and below 12 rib with ultrasound guided, like as you have shown us on the imaging. You use 90 degree, almost 90 degree 90 degree needle prick on the kidney. And most of the time, the hydronephrosis are moderate and severe. So it was easy for a success to place this stent nephrostomy tube.
Yeah.
Otherwise, for PCNL purpose, we never came across with this procedure at all.
Well, hey, I mean, if you're able to place a nephrostomy tube under ultrasound in the emergency room or wherever you're doing it, you're far ahead of many American urologists in terms of their ability to use ultrasound to get needle access to the kidney. So in terms of, you know, what skill sets you need in addition to do the PCNL, it's, you know, it's not much. It's really, it sounds like you know, resource dependent and getting the right scopes and lithotripters. So so that's great, because if you have that skill set already, you're halfway there.
Yeah, I think we'll have if you have like a workshop like that with you, live workshop, I think that might help a lot. So we do have a lot of patients. We do have the ultrasound. We only have a difficulties to get this energy source. Once we get that, I think if you have time, like to come here, so that to give us some workshop, I think that is easy, and
Yeah.
that's reproducible with our staff and residents also.
That would be perfect. I would love to talk with you more in detail about that. That's what the purpose of this low-cost simulator is, to basically be able to practice this. It sounds like you're getting those skill sets already, but then if we can work with people to get donations of equipment or whatever it takes to start to do this more reliably. We also have increasing ways to use technology to stay in touch and to actually help you during the case itself, using you know, telecommunications and augmented reality even sometimes. So that's a longer conversation, but I would love to come visit, and I would love to help you address some of these stones with new technology and new techniques, and so you're not having to open up kidneys to get stones out, because that's obviously not the best for the patients. But you can also teach me a lot about how to do that, because I never learned how to take out stones with open surgery. So I would love to learn from you all as well.
Thank you very much.
Any other questions about the talk or anything about my practice in stones itself? I think we can, you know, another time maybe talk about stone prevention. That's a whole nother talk with the medical management, the things that we do, and to try to prevent these from happening in the first place. But it sounds like you all have a huge backlog of significant stones that need surgery, and anything I can do to help with that, I'd love to be involved.
Yeah, sure. As you know, the Ethiopia is on the stone belt, on the world stone belt. So we do have a lot of stone cases. So we know everything. We read everything, and we follow that. We try to follow the guidelines from the EAU and the American Urological Association, and the like. On thanks to the COVID, also we do have a lot of webinar from the international experts, and videos also are on highly promoted on YouTube's regarding to these procedures.
Yeah.
And when we face with a patient, even with young patients, and when we think that we are going to open this kidney for small stone, we're very frustrated about the procedure, because we are not doing the standard procedures because of lack of these instruments and energy source and the likes. But still, we hope we will get that through something that's why we kept active on the urology service.
Great. Well, let's talk more online or offline about what kind of things would help you the most, and think about a time to plan a trip. That would be great.
Okay. Thank you very much.
To help coordinate that. Well, thank you,
Yeah.
Dr. Solomon, for helping coordinate this lecture, and Dr. Metzler for speaking.
My pleasure. Very nice to meet you all, and hopefully in person sometime soon.
All right.
Thank you
Bye,
very much.
everyone.
Bye.
Thank you. Bye.